So thinking about how we have discussed so far about high-risk disease and standard risk disease, and I think although we have slight differences in approach, which is great, that drives the science forward, and that's also brings us back to these meetings to continue discussing all the time. That's the fun part of it. So,
But isn't there that joke? If you ask 4 myeloma doctors, you'll get 6 opinions.
probably. So one thing I do still think that we agree on from what I've heard so far here today is that we agree that the high-risk disease patients, they need better therapies, and the standard risk patients, they can benefit from it, but some of us are maybe slightly more conservative, some of us are more aggressive. So
Early adopters.
early adopters.
Yes.
So now if we kind of think about that concept in the relapse setting here, so if you have a patient that say is complete response and it turns into biochemical relapse, is feeling fine otherwise, just there is this reoccurrence of the M spike, would you use a different therapy compared to a patient who starts having symptoms as the presentation of the relapse? Alfred, would you kind of give a less intense treatment for the biochemical, or would you do full speed there?
Yeah, so I again, there's not a lot of evidence to guide this decision, so this is very stylistic. But for patients who have biochemical only progression without a lot of complications and a slow pace, I tend to. This is a case where I especially consider using elotuzumab because I don't have much hope that later on it's going to turn around rapidly progressing disease, but it could maybe modify the effect of Revlimid. So if someone's on Revlimid maintenance, considering increasing the dose of Revlimid and adding elotuzumab, sometimes it works, sometimes it doesn't. But if it doesn't work, a couple months have gone by and you can usually pick up where you left off with something more potent at that point. On the other hand, somebody who you're worried about getting sick quickly, I think either a potent IMiD PI combination like carfilzomib and Pomalyst or a daratumumab-based combination are most appropriate.
Ajay, what's your thinking here?
Well, I mean, this is a very uncommon in a U.S. patient, right? Because the patient's not on LEN maintenance. And I think that's super important because we have 4 great RD backbone studies, right? ERD, IRD, the DARA-RD, and also KRD. And so then there's, I think, a role for each of those, right? So somebody who only wants oral therapy, IRD is great. If somebody really wants a very well-tolerated, it's an older, fragile patient, ELO is a great option. And if it's somebody who wants the DARA convenience, especially if it's sub-Q, that might be great. And carfilzomib, obviously, probably a little bit harder of a sell with twice weekly per label. I think a lot of us are doing weekly, but maybe for a biochemical, it seems a lot because to be giving that forever at that schedule is challenging. So I think, but there's a role for all of them. I think the one other thing to think about, which I agree with Alfred, that the ELO was really prominent for biochemical relapse, but now that ELO is also approved with POM, I'm not as worried about that sequencing issue. It's like it used to be a use it or lose it issue, and now there is a now downstream use of it as well.
So what I was trying to bring up here is that in the standard risk patients were newly diagnosed many years back, there were people who said you could do some form of a risk-adapted treatment. You could even give 2 drugs. You remember the old days when that was kind of on the table, and the people who communicated that approach said if you have high risk, then you need to have the 3 drugs. And we talked about the SWOG study here, which is an old study, was published 2017. That shows that if the standard risk patients get 3 drugs, that's really where you see the great benefit. And in fact, if you look carefully in the data, you see that the standard risk patients treated with 2 drugs have a worse progression-free survival than the high-risk patients with 3 drugs. So if you want to be a little bit silly here, you could say that if you follow the risk-adapted paradigm of treatment, that was worse for the patient than having a bad FISH signature even. So how about this biochemical relapse here? Are we talking about the same thing, that you could go for the best therapies at the biochemical relapse to try to maximize the benefit? Is that an opportunity, or
I think you bring up a really important point, which is that right now in the relapse setting, the FDA is probably not going to allow RD doublet therapies anymore, right? If triplet after triplet after triplet is showing superiority, what is the role of a doublet in the relapse setting?
That's the point I'm trying to get at.
I agree. I think, but the difference could be that if you start with a triplet, does everybody need all 3 of those drugs maintained forever? And I think that's where we, as the practicing physician with the patient at the bedside, can say, look, you've had an amazing response, your standard risk. I'm going to eliminate of these 3 drugs. I mean, everybody's least favorite, Dex, and then maybe even eliminate one of the other drugs and maintain. But I think that's a really important point. But I would also add that two of these studies have actually shown, the Aspire and Eloquent, although mature, not as mature, but have shown that PFS benefit is translating into OS benefit. Although the caveat is always drug access, so I think but the point is it's not that by doing this you're compromising later outcomes. It actually can translate. So I would just say, I think even if it's a standard risk patient, start with 3, but then maybe taper.
Yeah, I totally agree. I've stopped giving people just 2, and just to Al's point before, it's better, I think, for Synergy to give 3 and dose attenuate, or eventually like decrease the dex or whatever. You got to give them a shot because every single trial has shown 3 is better than 2. And remember that those trials often are based on people coming on with biochemical progression, and they make eligibility criteria, and their investigator puts them on. So.
One option that I think is often discounted, though, is for someone who's had a good response and maybe on Revlimid maintenance and it's been a long time since their induction therapy, is going back to the induction regimen. I don't think you have to move on to new drugs necessarily at first biochemical progression. If somebody, now this patient has grade 1 neuropathy, so I'd be reluctant to introduce Velcade, but in someone who didn't have any contraindications to going back to their induction therapy, I think that's an appropriate option as well if they tolerated it well.
Or second transplant if it's been 5 years.
Yeah, for sure.
I think you bring up a very important point, Alfred, that tolerance to prior therapy obviously will impact the different drug options we are thinking about. Patients with neuropathy, you wouldn't pick drugs that make that worse. Or if there were renal failure, you would stay away from drugs that were released through the kidney, for example. Last question I have here is if the patient was found to have a certain risk signature, say high risk, but the patient didn't clinically behave as high risk to begin with, and now we are talking about the relapse situation. Would you look at that old FISH results, Ajay, and say you must do this or that, or is really the clinical presentation that matters?
Yeah, that's a great question. I had a patient, for example, who was labeled as deletion 17p, and it turns out it wasn't plasma cell specific. So we repeated the marrow, and there was no 17p in the myeloma cells. It was in the rest of the marrow compartment. So I think we can get these weird kinds of issues. And I think, as we said, functional risk to me is much more important. If you had whatever high risk you were supposedly had, and you've had the induction, transplant, and LEN maintenance, and now you've gotten to the 4 years, that to me is not high risk. I still think we're using triplets for everyone, so it wouldn't in that sense make that big a difference. I guess maybe if somebody was truly high risk, would there be a role for a quad if they had symptomatic disease as well? But I think for now, I think the functional risk really trumps initial risk.
And the further you get from that initial diagnosis, the less relevant those results become. I mean, in some ways, everybody has high-risk myeloma. It's just people get to it in different amounts of time. Eventually, the disease becomes resistant to all available therapies. And at some point, people declare themselves as becoming more aggressive, and that can happen very unexpectedly and on a moment's notice.
To your point, both the CAR-T and selinexor, which is this heavily treated populations, about 50% of those patients have molecular high risk, but the rest are functionally high risk, right? Because if you've had in 6 years, then you're high risk no matter what.
Do you have any other perspectives, Nina?
Of treating the high-risk patients at relapse? Yeah, I think I would repeat the bone marrow because, as Ajay said, sometimes you don't find the things that you thought were going to be there. But I do think that if they had done really well for 4 years, it would be tough because if I found that 17p again, I mean, for sure, I'd
It's because you did such a great job with the maintenance.
Yes, thank God they got a transplant and maintenance. They did so well. But yeah, I would definitely repeat the bone marrow and see where we're at there.
I would like to thank Dr. Ajay Shari, Dr. Alfred Garfal, and Dr. Nina Shah for very thoughtful case presentations and lively, informative discussion. And to our viewing audience, thank you very much for joining us at this Targeted Oncology Virtual Tumor Board presentation. We hope today's discussion was valuable use of your time and that you acquired some practical knowledge that you can take back to your clinic. Thank you.